We have with us now Dr. Rejin Kebudi. She is Professor of Pediatrics and a Pediatric Oncologist at Istanbul University. Thanks for coming here and spending a few moments with us.
Thank you.
Let's talk about what you presented here at ASCO, and it was on second malignant tumors in childhood cancer survivors.
Yes, we know that the survival in childhood cancer has increased dramatically during the last decades. However, we do see late effects and, unfortunately, second malignant cancers. And in the childhood cancer survivor study of the TPOG Children's Oncology Group, this has been presented to be about 3.2% as a cumulative incidence. And so we aim to see what our results were in 20 years in the single institution, Istanbul University Oncology Institute, in 1,500 childhood cancer survivors. And we have seen 19 second malignancies in 18 children treated with cancer. We had 5 AMLs, that's acute myeloid leukemias, and the other were all solid tumors. And in the 5 AMLs, we have seen in children diagnosed with first a neuroblastoma, Ewing sarcoma, non-Hodgkin's lymphoma, and we had 1 osteosarcoma and 1 neuroblastoma, in fact. And some of these had been heavily treated for recurrences as well, which is a risk factor for second malignancies. And the others were all solid tumors. And in these solid tumors, we had some patients that had recurred in the radiation site, who had received radiation for their primary diagnosis, and some that didn't recur in other sites. And in these patients, we had 2 with medulloblastoma and 1 with neuroblastoma that had malignant peripheral nerve sheath tumors that had recurred in the radiation site. And also the other patients that had recurred in the radiation site, in fact, it wasn't recurring, it was a second malignant tumor. We had in 2 bilateral retinoblastoma patients, and bilateral retinoblastoma is hereditary, as you know. And one had a leiomyosarcoma, soft tissue sarcoma, and the other a bone sarcoma, an osteosarcoma in the radiation field, after 14 years both. And one had a meningioma, a retinoblastoma patient as well, a meningioma after 11 years after radiation. And one had osteosarcoma developing in a patient with nasopharyngeal carcinoma after 4.5 years, and also that was in the radiation field. And one also fibrosarcoma had rhabdomyosarcoma after 6 years in the radiation field. We cannot say that it was only the radiation that caused this, but it was an important risk factor. And the other patients that we had with second malignancies were not in the radiation field. One of these was a bilateral retinoblastoma patient who we saved both eyes and was cured for retinoblastoma and had osteosarcoma in the extremity, not in the orbital area, after 4 years. And also we had an osteosarcoma patient developing breast cancer after 8 years, a Ewing sarcoma patient developing sarcoma after 6 years, an ALL patient having Ewing sarcoma after 3 years, a mesenchymal chondrosarcoma patient developing breast cancer after 11, and the same patient, osteosarcoma, after 16 years. And very recently, we had a neuroblastoma patient who was cured with advanced disease. Neuroblastoma is sometimes fatal, and he was cured, and we were very happy. It was 8 years afterwards that we, on routine surveillance with ultrasounds, that's very important, so we have to have surveillance, because we could diagnose the patient at an early stage with a renal cell carcinoma. And there's very new data on some patients with neuroblastoma having second malignancies of renal cell carcinoma, which we did not know about it until recently. So this was also very interesting for us.
Based on the results you've achieved, what recommendations do you now have for treating children?
Well, these are all children with cancer, and we have to cure them because we really want them to be healthy adults. But when we are curing them, we have to have maximal efficacy and minimal toxicity. So nowadays, it's very important that we, after the trials that we're doing, to give less, especially, of course, this depends on the nature of the disease, the type of cancer, and the stage of the cancer. But to reduce the volumes of radiation, to reduce some of the doses, as far as we can, of course, we cannot reduce it as a whole, and also to give the minimal chemotherapy that is needed for maximal efficacy, because we do know that anthracyclines and alkylator agents may cause at least are a risk factor for second malignancies, and radiotherapy is also a risk factor for second malignancies. And also we have seen this in the last decades, like for example Hodgkin's disease. We used to use more the radiation volumes, and the radiation doses were much higher in previous years, and also the number of chemotherapy cycles was much higher. But we have shown in the past decades especially that we could reduce the number of cycles and reduce the volumes, and even in some patients that have complete response after chemotherapy, we could omit radiotherapy. So since these are very young patients and have a high risk of late effects and also second malignancies, we have to be very careful when we are deciding the protocol for these patients that's using the chemotherapy and radiation. We have to use it because we want to cure them. But when we are using the protocol and we are deciding on the protocol, we have to decide on, when we're making new protocols, we have to be efficient but less toxic.
Dr. Kebudi, thanks for stopping by and sharing your work and all the great things you're doing on behalf of children with cancer in Turkey.
Thank you for giving me this opportunity, and I wish all the children healthy days.